Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Axome. Earlier this year, Dr. Nancy Collop turned over the keys of the JCSM to the new editor, Dr. Safwan Badr. Dr. Collop traditionally gave a talk at the Sleep Medicine Trends meeting, covering the top 10 articles in the JCSM. We thought we would try to tackle something similar today, but with a few twists. Dr. Safwan Badr joins us today in his role as the new editor of the JCSM. He is a sleep medicine physician at Wayne State University and is here to share some of the articles that were published in the JCSM this year and to update us on some changes at the journal. Welcome. Thanks for being here today.
Thank you for having me. Appreciate it.
So congratulations on your appointment as a new editor for the JCSM. I understand that we should anticipate some changes.
Yes, thank you. I'm actually honored and very pleased to assume this role. I know I have big shoes to fill with Dr. Kwan and Dr. Collop. So one of the things, journals are like human beings, they evolve. And the board of the American Academy of Sleep Medicine developed a strategic plan, a new strategic plan for JCSM. And the goal is to make this journal what it actually should be. A world-class organization like AASM deserves a world-class journal. What this means is evolving the role, which still will serve our membership, from a platform for all types of contribution to contribution that really, truly advance the field. So the emphasis in the near future or in the future is on soliciting and publishing top science, absolutely top science that moves the field. We have metrics for this. For example, we want things that are novel, things that are new, things that will change the field. And we know that things that are novel and change the field are more likely to be cited by others. So we want the membership to read it. We want them to access it. We want them to feel that this is important to them. But we also want other scientists in the field all over the world to actually look to JCSM for the novel top science that's published. So it required some changes, which again, changes always has challenges. That there are certain things that we will no longer accept. For example, case reports are important to many of members, but they probably need a different home because they require a different way of looking at them. So we're emphasizing high quality original science, which will include meta-analysis and reviews that will kind of advance the field. Obviously, we will always have position statements from the board and standards of practice, which are really, really important to the field. So to achieve this, we're emphasizing also providing an outstanding author experience. So we're trying to streamline the review process and make it more efficient and user-friendly. Again, some of these changes will take time to manifest, but that's our goal. Now, we are open to input. I ask the membership to email me, to reach out with any ideas or suggestions to make this journal better. Again, this is your journal, it's the field journal, and we want to make sure that everybody feels that it's theirs.
So how do you decide who makes it into the journal?
So one of the things we've done right now is we're looking at, we've expanded our editorial board. So if you look at the JCSM, you'll see that the editorial board is the largest that's been. And we're trying to bring experts from a variety of fields. For example, we solicited and we sought biostatisticians because some clinical trials require specific analysis. You really don't want me to review the biostatistics of a manuscript, and that actually will increase the rigor.
Okay.
So we're really talking about. I have kind of a three metrics. Is it novel?
Okay.
That's one. Is it valid? Again, validity is an important thing. And does it make a difference? Would anyone want to cite it? A paper that doesn't get cited is a cul-de-sac paper. And cul-de-sac science doesn't go anywhere. I love papers that at the end ask questions. At the end of the day, leaves open, show you the highway, show you the mountain. Like, okay, we've gone this far, but all of these questions that opened up, and that's how the journey of science is. So we want articles that gives answers, but also open up new avenues and open up new directions and make us ask some difficult questions. And by the way, I used this approach in selecting some of the articles that we're going to discuss today.
Oh, good.
Is that I want things that like, you're making me think.
Well, so let's talk about some of these publications. So I will put out one caveat is that we have done and plan to do specific podcast episodes for each new guideline. Okay, so I know that you had Plato, for example, as a new questionnaire. You wanted to talk about that one, but we actually did do an episode on Plato. So let's talk about some other ones. And I'm hoping you can share not only the most popular ones, but perhaps some that didn't receive as much attention, but are clinically important. So where should we begin?
Okay, so maybe as a start,
Yeah.
when you ask me, since the title of the top 10, I am as an editor, I don't have a top 10.
Okay.
I view all the articles as like a parent views their children.
I
love
wondered
them
if you were
all.
going to say that.
Okay, I love them all. Okay, so I picked a few that it raised some questions in my own mind. So this is in no way a ranking system.
Okay.
This is no way to say that these are the best. And you're right, some of these may not have received as much attention, but to me, I selected them because they made me think, and they challenged me a little bit.
So can we talk about this one? It is called Lower Slow Wave Sleep and Rapid Eye Movement Sleep are associated with brain atrophy of Alzheimer's disease vulnerable regions. So talk to me about this paper.
Okay, well, this is a very interesting paper. We've been talking about sleep and Alzheimer's disease for a long time, and everybody tells us sleep is important, sleep is important. But this study the beauty of it is that it's a longitudinal observational study. They took 270 normal middle-aged adults. And this is part of the atherosclerosis risk and community. So it's part of the ERIC cohort. So, and looking at are changes in sleep architecture or sleep architecture measured in late midlife predicts neurodegeneration later. Specifically, they looked at slow wave sleep and rapid eye movement sleep. So this is actually very interesting. So it's a longitudinal observational study. They did polysomnography, and somewhere 13 to 17 years later, they did an MRI of the brain. And they looked at different vulnerable regions and also examined whether these variables predicted cerebral microbleeds. So looking at small vessel disease, like a different mechanism, because we know about sleep and vascular disease. So they found, to make it kind of in brief summary, that lower slow wave sleep and lower REM sleep, each one of them was separate, predicted meaningful changes, predominantly inferior parietal atrophy. So we're talking here, you don't have enough slow wave sleep, not enough REM sleep. It actually associated with parietal atrophy. Now, we talk about arousals a lot. Arousal index didn't seem to have a specific relationship. And they did not predict cerebral microbleed. So it's not through the pathway of a vascular disease.
Okay.
So I think this is important as we emphasize sleep duration, sleep continuity, and the fact that there is no association with microbleeds. Said it's a distinct mechanistic pathway. It is separating neurodegeneration from cerebrovascular injury. And so I think, and the fact that it's longitudinal, it's actually, and adjusted for numerous confounders, it does really strengthen the case that sleep architecture per se, not just comorbidities, may play a meaningful role. Now, like every studies do have limitations. I mean, this is a one-night polysomnography snapshot. It's an observational. It cannot establish causality. But the strength, on the other hand, it's a long-term follow-up, up to 17 years. And they used objective PSG measurements and an MRI measurement. So I think it's an important study. And for me, this is the issue. It's opening up further questions. It's creating, it's like, we need to know more.
So how did they define lower slow wave sleep in REM? Was it percentage? Was it absolute minutes?
It was a percentage, I think.
Okay. So then it wasn't necessarily sleep duration, right? It was a lower percentage of time, of total sleep time spent in
Yes, it
delta
is
and
percent.
REM.
Absolutely. It is
Okay.
percentage. Yeah, 1%. Yes.
Huh. Because you kind of wonder, right? If they have short sleep duration, then wouldn't they also have lower slow wave sleep in REM?
That would actually make sense, and that's actually again one of the issues we need to decipher in the study. Absolutely.
Yeah. So then one of the conclusions that I read was that they felt that sleep architecture may be a modifiable risk factor for Alzheimer's.
Mm-hmm.
And so what I'm kind of wondering is, okay, fine, we have objective, we say they have lower delta and they have lower REM, but then how do you improve that? Did they tell us how we can
That's what
strive
they
to
did.
improve it?
That is the new avenue that it opens up.
Oh, okay. Okay. All right, I'm
So
with you.
yeah, so I think that's the idea, because we do not know is that in and of itself, for example, a function of sleep duration. So for example, if I'm curtailing my sleep and waking up and 2 hours earlier than I should be, maybe I am curtailing my REM percentage.
Right.
If I'm going to bed a little later, maybe I'm also curtailing my slow wave sleep. So maybe these things are intertwined, and it may not be easy to dissect them.
Right. And
Personally,
then how,
I think sleep duration and timing
yeah.
might actually be the critical piece that drives both. But I obviously do not know that for a fact.
Yeah, but you're right. Okay, I kind of see where you're going with this, that it challenged us to ask more questions.
Exactly.
Right?
Exactly.
Okay. Okay, so it's interesting. All right.
It challenges us to ask more questions and tell us that, and again, this is the fact that it's combining time, polysomnography, and MRI is telling us a story. There is a story here, and our job is to dig a little deeper. If you ask me, I would say probably optimal duration and timing may be the thing that we can do to increase both of these.
So were the people who were selected for this study, did they have any sort of family members with Alzheimer's? Were they chosen because they were at higher risk, or how did they determine
they're normal adults, as far as I can tell from the paper.
Okay.
They're normal folks.
Interesting. So then
It's
if
a
you
community
see,
dwelling middle-aged and older adults.
yeah. Okay, so then if you identify this, and obviously assuming no sleep apnea, no, any of those other things, right? That maybe this is a signal that, okay, maybe we need to really do some work on education for sleep duration and, all of these other things.
Right. So I see this is exactly the kind we start many studies with observation.
Yeah.
This is a longitudinal observation. It adds to a body of literature that is showing us that there is a signal here and we need to pursue it. Now, if we step back and think broadly, is this is a huge change. Like when I did my training in the Jurassic era, nobody was talking about sleep duration. This was not, sleep was basically sleep apnea. And then everything else was a couple of sentences.
Okay.
And right now, this is it's telling us there's more to the story. And this is moving the field from a sick care, which is treating condition, to actually sleep health. And I think this is one area where actually our field has made tremendous strides forward. And this will go in that direction.
Okay, so let's go from the Jurassic era into the future. Let's talk about this review article of wearables versus PSG. Performance of consumer wrist-worn sleep tracking devices compared to polysomnography, a meta-analysis. So that's the title of this article.
Mm-hmm.
Tell me about this.
Well, so this is the reason I like this one is I've been looking for something like this, and there's so many publications now, as the saying goes. If I get a nickel for every time a patient or a friend of mine pulls whatever their wearables and ask me to diagnose their future and their life expectancy and their net worth from these numbers, I'll be very rich. So this article is actually helping us in that direction. So this is a meta-analysis, and they reviewed a large number of studies that addressed the tracking devices, all of these devices. So 24 studies, almost 800 participants. So this is a pretty large number of studies. Now, again, a limitation up front is that it measured a bunch of consumer sleep trackers.
Okay.
So did not look specifically at each one of them. And the question is...
Oh, that's interesting.
So it is not a one device. I mean, there are 7, 8, 9. I have no idea. I mean, everybody I know has a device, and this is a useful, usually a dinner conversation. Everybody pulls their devices and they start comparing to others.
Yeah.
So this is comparing to results from all of these or multiple of those. I don't want to use the word all.
Okay.
Wrist-worn devices to PSG across course sleep metrics. They looked at sleep time, sleep efficiency, sleep latency, wake after sleep onset. And then they started to doing some brand analysis and healthy versus clinical population. And then they did something very, very interesting, which they looked at studies pre-2020 and post-2021.
Oh.
And I think that's an important thing to know. In this field, what I know today, we know is unlikely to be correct a year from now. So overall accuracy, the devices differed by about 17 minutes on total sleep time. Many of the devices underestimated sleep efficiency, slightly, not a lot. And having used 3 or 4 over the past 10, 15 years, I can attest to that. I argued with my tracker all the time. And sleep latency, they seem to overestimate latency. And some of them overestimated WASO, some of them approximated WASO. So, and again, it's a wash.
Yeah. Okay.
So what's the major kind of takeaway from this is that there's really, for the most part, they all differed a little bit, but they're not that huge of a difference between different devices. And the most important finding for me is that everything after 2021 seems to be better, especially total sleep time and sleep latency, which tells us that there is an improvement. The algorithms are improving. They're incorporating feedback and input and probably additional studies. And again, many of these studies are studies we do not have access to. They're proprietary. So I think that tells me that soon enough, these devices, at least some of these devices, may be accurate in some of their estimation. But as of today, they are not, I wouldn't call them accurate for clinical diagnosis, especially for insomnia or something that requires EEG-based staging.
Sure.
But trending in a given person, I think, will be useful. So my device is saying I slept only 5 hours. 2 weeks from now, I improved my sleep and it says 6 hours. That is actually useful. So trend within a person as opposed to comparing individuals.
Well, and I feel like, when this whole conversation started, I think it was will this replace HSAT PSG? And I feel like as a field, and even in industry, right, with technology, I feel like perhaps we have evolved to a place where we recognize that there's value in the objective legacy testing devices, but perhaps there is a new role for wearables in terms of, like you mentioned, longitudinal monitoring and, hey, we did this, we started CBTI here, let's see what happened with your sleep. Or we started CPAP here, let's see if there is a change. And then, of course, most importantly, when you ask your patient, do you feel like this reflects your lived experience? You know, because I've had some patients say, yes, every time it's exactly right. And other people are like, nope, not even close. And so I feel like that's part of the conversation.
I think you hit the nail on the head. This is exactly where I see it useful in a given patient, because this study, this analysis showed that there's no difference between healthy population or a clinical population, and to me, this is actually useful. If somebody has a device, and I see patients with insomnia in my practice, that's exactly how I would be using it. Now, one of the things I also want to caution from is for of us individuals, or especially people in the field, is not to develop an obsession with this, because
Yeah.
this is actually, I think there is a new term, orthosomnia,
Yeah.
which is
Kelly
an
Barron.
unhealthy
Yeah.
obsession with achieving perfect sleep. And I think that is, I mean, kind of my joke about myself is that I wake up in the morning, before I do anything else, I open my phone, look at my phone to see, how am I supposed to feel today? That is not how these
Right.
things are supposed to be used.
Yeah, no, Kelly Barron, I think because she coined that phrase, right?
Yes, that is Kelly
Orthosomnia.
Barron. Absolutely.
Yeah,
That is
which
Kelly
is
Barron's term.
so, but you just dropped a little pearl in there hidden. You said that the study demonstrated that there was no difference between a clinical population and a general population.
Mm-hmm.
Clinical
Yep.
meaning
Patients with sleep disorders. So I'm using
with
this
sleep
not
disorders.
so I'm viewing this as I can use it to track in my own practice, knowing a given individual. I mean, and I think you gave me an insight into this when you said we talk to the patient about their lived experience.
Yeah.
So if you talk to a patient and you look at this and say, yes, this reflects how I feel, or this is accurate for me, or this reflect me, then
Yeah.
actually trending it is useful.
Yeah.
But I think this conversation, if we're having this same conversation a year or two from today, we may be having a totally different conversation. I think
Yeah.
technology is evolving at a dizzying pace.
You know, and it's really interesting. One thing I have grown to appreciate is that these wearables are not all the same. And I appreciate how some of these big tech people actually have sleep physicians on staff.
Yep. Mm-hmm.
I mean, that's huge. So
Yes.
this
So
was
they're incorporating input, and that is
yes,
actually that's actually what a learning organism is, and we all
yeah.
should be learning organisms.
And I feel like some of them are really respecting where the science is leading us, right? Like they'll base decisions on papers that were published, not just sort of so like, you know, the engineers will say, oh, we can come up with these metrics, X, Y, and Z, but at least they have a clinical person saying, okay, but we don't care about X and Y. We only care about Z, and please also give us a W. So,
Exactly.
Right? I feel like that's important.
Exactly.
So this paper was on wrist-worn sleep trackers, right? So
Correct.
can you apply it to rings?
I see no reason not to, because they're tracking based on to a large extent similar approaches. I think I personally, again, I haven't validated it, but in principle, why not?
Interesting. Okay, I thought you were going to say the opposite, actually.
Yeah. Well, I mean, I'm simply guessing here, based on they are tracking something from the surface.
Yeah.
And I don't see that conceptually as very different. Now, an engineer may argue with me. A purist will tell me I'm wrong.
Okay.
But that's an equal guess. But then maybe it's an invitation to have more studies on these.
I love that. At least for the conversation.
At least for the conversation.
Yeah. So let's take a short break. And when we come back, we'll talk more about some of the most notable articles published in the JCSM in 2025. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with the editor of the JCSM, Dr. Safwan Badr. He is taking us through the most impactful articles published in the JCSM this year. So let's talk about that Canadian study about insomnia in pregnancy. This is the one that was called Sleeping for Two, a randomized controlled trial of cognitive behavioral therapy for insomnia in pregnancy. Tell me about this one.
Well, this is a clinical trial, a good old-fashioned clinical trial, and I love those. And think about clinical trials is that you have no idea what you get till the envelopes are open at the very end.
Okay.
So for an impatient person like me, it's a learning experience. So this is the 62 participant parallel arm RCT. They comparing 5 sessions CBTI, sleeping for 2, which is a very clever name, delivered in person or telehealth to a treatment as usual, which is waitlist, nothing specific,
Okay.
for pregnant individuals with clinically significant insomnia at 12 to 28 weeks of gestation. Now, uh, obviously, sleep disturbances during pregnancy are known, but insomnia somehow didn't get the attention that it deserved. And what they found is that CBTI reduced insomnia severity as measured by ISI immediately post-treatment, and the improvements were maintained at 6 months postpartum.
Oh, wow.
That is actually significant. Now, remission rates were higher in CBTI group, reached statistical significance at 6 months, 16% versus almost 45%, still meeting criteria. So this is also a significant difference. Sleep quality as measured by PSKI improved more with the CBTI. Sleep diary, sleep onset latency improved with CBTI. But there's always a fly in the ointment in science. Actigraphy-based sleep parameters didn't show differential change, which is not surprising. We see this in the literature a lot.
Yeah.
And the other important thing, which is useful for anything time we do about treatment, and especially CBTI, telehealth was just as effective. That means it's supporting scalability and accessibility, because we all deal with the issue of not enough providers of behavioral sleep health. And now telehealth is just as good. And obviously, it's always important. There's no effect on birth outcome or infant sleep, although these were exploratory.
Okay.
So I think this is it. I'm very happy when I see that we're starting to study insomnia across different populations, because the original studies of insomnia were individuals with insomnia only and nothing else affecting the picture. And the question is always, is can this be applied to this population or this population or this population? Now we're starting to look at it in insomnia and sleep apnea with COMISA.
Sure.
That's kind of the first starting point. But I think this is a welcome addition to the literature.
So tell me about the patients. Or the trial participants. Did they have insomnia prior to pregnancy, or was this sort of pregnancy onset insomnia?
I'm trying to see if this was actually made very clear. It's not clear to me from the paper whether it was or not before. I think it was during, because again, that's how they were seen.
Okay, that's fair. That's fair. And then is it just regular CBTI, or was it modified?
It appears that it was modified. I didn't see sleep restriction as one of the elements of this one. So my interpretation and that it was adapted and sleep restriction didn't appear.
Yeah, that was kind of my thought, because I think I would be apprehensive about sleep restriction in pregnancy.
Agreed.
Yeah.
That is very important point. How much sleep restriction can you actually do?
Yeah. Because I think I would, having been pregnant twice and it was no walk in the park for me, I would not be enthusiastic about sleep restriction during pregnancy.
I think you are absolutely right. And anytime, and this is actually the same thing. We're studying it in different clinical population here.
Yeah.
And this is the area where we had to make some changes. We had to make some modifications. I think in principle, there is we need to actually account for that. So yes, they did have, I'm looking here, they have obviously the education, they have stimulus control, and they have cognitive strategies. So it's not clear how much sleep restriction and whether that was one of the things that they varied.
Yeah, because it's probably like a kinder, gentler.
It probably is.
Okay.
It'll have to be. Yes.
Yeah. Yeah. I mean, some people glow and have wonderful pregnancies. I was absolutely not one of those. So, It was, yeah, I would have been very, very reluctant to consider any sort of sleep restriction, but that's my N of one.
Well, but that's another thing that tells us is that, and this is you're highlighting such a critical point in medicine. We are dealing with humans with their own individuality and lived experiences and challenges. And anything we do has to account for that. It's not an assembly line. And this is, you're right. You're absolutely right. This is actually a very important point.
And it does kind of lead us to the next article a little bit. This one is called Using Expanded Diagnostic Criteria Mitigates Gender Disparities in the Diagnosis of Sleep Disordered Breathing. So for this one, I actually see that you're an author.
Yes.
So
yeah,
tell me about
conflict of
this.
interest.
Yeah. So how do you navigate being an author and an editor? Do you recuse yourself? Do you just get to put yourself in there? Like, how does that work?
Well, that actually is we have a procedure for anyone, especially for the editorial leadership team. We don't see it. We have no idea what happens to it.
Actually,
the staff handle this completely. They will direct it to another. There are 3 deputy editors whom I have the pleasure and honor of working with.
Okay.
And they are Dr. Babak Mukhlisi, Dr. Jennifer Martin, and Dr. Kathy Goldstein. And I don't see it. I have no idea who handled it. It's let's say, and when we have a paper that any one of us, and again, we love the journal and we want to submit our work to the journal.
Sure.
So I think each one of us, the 4 of us, has things that are submitted to the journal and they don't see it. We have no idea.
Really?
I have no access to it completely. By the way, this was reviewed before I became an editor.
Oh.
So but if it happens now, if it happens now, that is exactly what will be. Then none of us will see it.
So when we were preparing for this, you shared with me that there were some things that changed in the way that you guys decided which articles were accepted and which ones were not. Mm-hmm. And how it used to be that, and tell me if I have this right, that associate editor or deputy editor could say yes or no. But that has changed now.
Yes. So actually, yeah, the change in how the process of accepting and rejecting is and I've learned this having served on other journals as well. I've learned it from others. So it's the field we learn from each other.
Yeah.
So when a manuscript is reviewed and the associate editor says, we recommend major revision, that this moves forward. What we do in the past, it used to be that the associate editor alone can make that decision. And now what we do is that we put a pause. So every Tuesday at 4 p.m. Eastern Standard Time, I meet with the 3 deputy editors and the staff of the journal, and we go through every one of those that has been recommended to move forward.
Oh, wow. Okay.
So, and the reason is we want to kind of have the global picture, the global feed. And we ask these 3 questions. Is it valid? Do we have any issues with validity? Is it novel? Does it move the field forward? Not an incremental, not a me too, not a slight incremental. Is it really challenge something? Is it moving the sleep? And the last one, would it be cited? Is it? And again, to me, that's a marker of how the field is viewing it. And sometimes we make some recommendations that are a little bit different. For example, we had a recent manuscript where we felt that it was a specialized area of expertise that was needed. If it's some methodology that I can't even understand, I can't even pronounce, or none of us can, that means probably the reviewers, and we looked at the reviewers, they were folks like us.
Okay.
We felt we actually did some search trying to find an expert in that specific methodology.
Oh, wow.
It delayed the process a little bit. I emailed the author and apologized to them and told them this is why this has been delayed a little bit, because I want to make sure that the methodology, which is one of very few times I've seen it, that this actually valid because I couldn't adjudicate it. And sure
Oh.
enough, we got within a week an amazing methodological review that went straight into the methodology. Now the authors will, as they make the revisions, their paper is going to be much stronger.
Isn't that something?
So this is what we're trying to do. And sometimes we do a literature search as we are reviewing in our meeting, to the extent that I started joking, should we start getting CME credit for this meeting?
So it's interesting because that has come up before, that having a methodologist. So we learned about that when we had a conversation about Plato.
Mm-hmm.
And I did not even know that that was a thing.
That is a thing.
Right.
Yeah, absolutely. And I'm learning that, I mean, I see articles and submissions in areas that I know nothing about. For example, we now need, other than the statistics and epidemiology, which we've always known we need those, but now we're getting things that are looking at AI, looking at a whole bunch of things that we would never think of. Like, for example, this one we just reviewed a few minutes ago about brain imaging.
Yeah.
Well, we probably, for something like this, there would need to be an expert who knows something about brain imaging.
Yeah, that's fair.
And we're trying to populate our editorial board with this kind of specialized expertise. The beauty of sleep, because it is not organ-based, it touches every organ. So we will always find that we need experts in different areas.
I love that.
And then we're trying to add some to the editorial board, or on an ad hoc basis, reach out to experts. And that's the beauty of having an expanded editorial team, is that we can start thinking of names of people.
Yeah.
And that's why I said sometimes we do a search and say, who does research in this area? Who can tell us about this methodology? I think a very important contribution we can make to the field is to make sure that the science that's published in JCSM is of the highest rigor.
Yeah. So I love that, and I love that it's very collaborative, right? Because I feel like sleep is by itself, it spills into everything. So by nature, it should be collaborative.
Absolutely.
So let's talk about this paper now that you kind of you didn't have to recuse yourself. You got to, be published in this journal. So tell me about this paper.
Well, this is one of these scientific issues that have been evolving. And if you allow me kind of go back to history a little bit, if we look at sleep apnea as a disease or sleep disorder breathing, going back to the 70s to the original literature, and I love to go back to old studies, it was all men.
Yep.
100% of it were men.
Yep.
And then people took what the symptoms of that these men displayed, and they made them the symptoms of the disease.
Yeah.
And then they told the women of the world, well, welcome to it. You just have to fit in it.
Yeah.
So if your symptoms are different, you're presenting with quote unquote atypical symptoms.
Right.
But guess what? We will not accept this for any methodology right now. They were not in the original cohort. And one of those is the desaturation.
Mm-hmm.
And any respiratory physiologist will know the distribution of obesity in men and women differs. So if you are supine and sleeping, your FRC is smaller as a man than a woman who has the same BMI, which means you are more likely to desaturate.
Right.
And if we're measuring a hypopnea by a consequence, we are more likely to capture hypopneas in men. Now, apneas are not difficult because apnea is cessation. We don't care whether you desaturate and never desaturate. But the hypopnea, we have no way of measuring a 50% reduction in alveolar ventilation.
Right.
If we throw that as a number. What we have are what happens after. Either you desaturate or you wake up or you have an arousal.
Yeah.
So then you look at a whole lot of studies that basically before 1993, 9-to-1 ratio for sleep apnea. And that's because people weren't even looking at the symptoms. And actually, the credit goes to Terry Young, who challenged that paradigm in her study in 1993. And so now we know that this condition is more common in women, but women were not included in that original definition.
Yeah.
So the academic criteria for scoring events would say 3%, you don't need to have 4%, 3% or arousal. And that actually now captures a broader swath of people who have the disease. Now, this study is from a population in a clinical center. So these are all symptomatic patients who came to us saying, we are sleepy, we snore, we're tired, we have all the symptoms. If you look at 4%, you will find that less were diagnosed than if you actually, if you make the 3% or the arousal, especially in the mild to moderate. So there are, and we've all have this, I'm sure you have it in your practice, women who present to you with all the symptoms, but then you can't make the diagnosis.
It's a conversation literally every single day in my clinic.
It's a conversation every day. And I'm not saying that we treat a number,
right?
But these are symptomatic individuals who are coming to us because they have a sleep problem.
Right.
And again, this is what the origin of that, when Christian Guilleminault described the upper airway resistance syndrome.
Yeah.
In one of his papers there, he said, like, it took 19 years for one woman to actually receive the diagnosis. So
Did it really? It took 19 years?
In one of his papers here is that one example, one specific patient took her 19 years. So again, because we're saying atypical symptoms, and they weren't meeting the criteria. Now this conversation is a long time ago, but again, it's an important one. So about 7% of the women who did not have the diagnosis made it into the diagnosis. 10% became moderate. So it's clearly affecting. It's affecting the diagnosis. Again, this is not population. This is patients with complaints who have all the presentation of sleep disorder breathing.
Yeah, it's funny. When I was a fellow, 100 years ago, once upon a time when I was a fellow, I remember putting the oximeter on my finger, and then I held my breath as long as I could. And my sat did not budge.
Your sat will not budge. You have a healthy lung, and you're a young, thin, healthy woman. So yeah, it will not budge.
In that moment, I was like, oh, okay, hang on. Like, how am I going to ignore something like that? I wasn't smart enough to actually do anything with that sort of epiphany I had. I just parked it in my brain instead of maybe actually like doing some research or talking to somebody about it. But when I read papers like this, I'm like, oh, okay. Yeah, that makes sense to me. But you're right. And I feel like this knowledge also helps validate the concerns that our female patients have.
Absolutely. There is nothing, I have a term for this.
Okay.
Medical gaslighting.
Oh, yeah.
It is basically somebody is coming to you with a symptom. There's nothing wrong with you. We can't treat you. Go figure it out.
And I have to tell you that I've been on the other side of that. So I remember when my oldest was little and there's something wrong with her. We took her in to the pediatrician at the facility where I worked. And, when I did pulmonary and crit care, and the locum pediatrician blew me off. He's like, there's nothing wrong with your kid. And literally, I ruminated about it. And then I called that night. It happened to be the on-call person who happened to be her pediatrician. She diagnosed her over the phone and called in a prescription. It's infuriating. Because, like, why do people pay money, spend time, go to the doctor if, like, there's truly nothing wrong?
Exactly. Why do we negate and ignore and sweep aside the complaint and the lived experience of somebody? It's an Occam's broom. We sweep under the rug things that don't line up with what we want.
Well, and I literally had to have a conversation with myself when I got home, and I was like, okay, hang on. I am a quadruple board certified physician. Like, I know there's something wrong with my kid. I'm not a pediatrician. Like, I don't know what it is. but I know that there's something wrong with my kid. And if I am experiencing this and having been in the medical world, like, forever, imagine people who don't have that privilege like I do.
Imagine what they would have to do. They'll go doctor shopping.
Yeah.
And or they'll get depressed, or it will affect them in so many ways, and we are not serving them. Again, maybe this has nothing to do with sleep per se, but at the end of the day, we are treating a patient, a fellow human being, who is coming to us, putting their trust in us. There is no bigger honor than somebody trusting us, and then we blow them off. It is actually infuriating. I'm actually feeling angry just hearing what you're telling me.
Maybe I need to email you a little beta blocker or something. This year marks the AASM's 50th anniversary, a milestone that's given us a chance to reflect on the people and moments that have shaped the field of sleep medicine. To honor that legacy, we've gathered heartfelt reflections from the sleep luminaries who have helped pave the way. If you'd like to share in those memories and stories, please visit the AASM YouTube channel to watch our anniversary highlight series. Now back to our conversation. So let's switch a little bit and let's talk about young adults with type 2 diabetes. So you sent me this article, and I will tell you, I was surprised you sent it to me. Until I kind of read it. And then you also sent me a commentary. So this study is called Obstructive Sleep Apnea, Glycemic Control, and Cardiovascular Risk in Young Adults with Youth Onset Type 2 Diabetes. Results from the Today study. So tell me about this. What was the Today study?
Okay. Well, before I tell you a Today study, I'll tell you why I like it.
Yeah, tell me.
I am one of those people who believe if you want to find the way forward, go against the party line, whatever it is. And this study, there's something about it's going against the party line because it's finding something totally novel. It's opening up new avenue. It's making us think. It's actually the thing about this study, it's giving us more questions than answers. So this is based on the Today study, which is a large treatment options for type 2 diabetes in adolescents and youth. And what they did in this one, they looked at 114 young adults with youth onset type 2 diabetes, about 10 years after diagnosis. So they're pulled from that cohort. They did an in-lab PSG, and they did a whole bunch of metabolic and cardiovascular risk markers. And what they found, a few interesting findings. One is that the OSA prevalence was about 38%, slightly less than 40%, which is lower than older adults with similar BMI. That's one.
Okay.
These OSA tended to be on the milder side, but then there was no relationship, this is the key finding, between OSA and hemoglobin A1C levels, insulin sensitivity, or beta cell function. And also no association with hypertension, dyslipidemia, nephropathy. So it looks like type 2 diabetes in this population is kind of riding shotgun. It's not the driver. It is just sitting there.
Okay.
And that is one of the things that the editorial, the commentary wrote about it, is that it makes it why? The question is why? And maybe that a lot of the cardiovascular complications that we think of are not necessarily always mediated by us. That age may be a factor we're not accounting for. So when we see an adult, a 48-year-old or a 55-year-old who has type 2 diabetes, well, first of all, most of the time they're obese. They've had this for a longer period of time. Maybe age has affected their ventilatory control, affected their upper airway function. There's a whole lot of things that are actually different in them. And even though they also have diabetes, so diabetes may be a co-conspirator, but it is not the sole driver.
That's interesting. So the commentary that you sent me, they talked about how youth onset type 2 diabetes may not just be early onset diabetes, right? But maybe its own distinct clinical entity.
Correct.
And so I sat with that for a minute because I really had to think about it. My brother is an endocrinologist. And so then that made me kind of think about, like, what message should we be sharing with our pediatric endocrinology colleagues about this and the relationship between obstructive sleep apnea and diabetes? Is it something just saying, maybe have the conversation, and do we screen them earlier for sleep apnea, or what is that conversation?
Well, I mean, it's still a 40%, 38% had sleep apnea. So it's not like it's not there. And we need to treat the sleep
Oh,
apnea
that's fair. Yeah.
for its own reason to treat sleep apnea. I don't want the message to be a nihilistic one to say, don't look for it and don't treat it.
Okay.
But it is, so to me, there is the diabetes, there is the obesity, there is the sleep apnea. Each one of them have to be treated for its own reasons and not necessarily link them, because the message we have for middle-aged and older adults is that we mix them together. We say your sleep apnea is contributing to poor control of your diabetes. That horizontal message we cannot make, but I wouldn't take the message not to look for sleep apnea and not to treat it.
That's fair. I like that. And maybe just inform the conversation with
maybe
with
inform
our
the conversation, but it opens up also pathophysiological questions, which I'm a physiologist at heart. I like mechanisms. Is that means there could be something, another variable beyond diabetes that's contributing to the other adverse consequences, and we need to think about them differently. And that's what they're proposing: either age, upper airway mechanics, ventilatory control, aging of the carotid body. I don't know. Anything else I would say would be speculative.
So, any other final thoughts about all of the cool articles you've read this year?
Well, my final thought is that we want more. Send us your thought-provoking articles. Send us your study that could potentially change the field one of these days. We want to see the studies and publications that will transform the field, that 20 years from now, somebody will look back and say, what we think about today, what we know today, started with this original study that was published in JCSM. And that is my plea and appeal to all my colleagues in the field.
And maybe don't be hurt if your paper is not accepted, but maybe take it as a challenge to work it a little bit and make it a little bit more novel, stronger. Like you said, right? A little bit stronger. Yeah,
exactly. And if it's any consolation, I've had more than my fair of rejection, share of rejection. So anybody who stays in the field, we all know that we have to accept rejection. You fall 7 times, but you rise 8.
Get up 8. Yes, I love that. Well, thank you for joining us today and giving us a tour through some of the new changes at the JCSM, as well as highlighting the articles you felt were the most impactful in 2025. I might hit you up for this next year. Maybe we can make this an annual event.
I would love to. I think it would be a lot of fun.
Thanks for helping us wrap up our 7th season of Talking Sleep by the AASM. We wish you all the happiest of holidays, and we'll catch you in the new year. We will be back in mid-January 2026 with more episodes to explore new advances in sleep medicine. Wishing you and yours peace in this holiday season. Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.